Your patient is vomiting and their head is throbbing. Maybe it's a migraine or gastroenteritis, but then you notice something strange about their pupil. One is dilated and it's not reacting to light. Should have paid more attention in the ophthalmology lecture. Or you could just watch this because you need to act fast. A 62-year-old woman comes to your ED just after midnight with severe right eye pain that started a couple hours ago. Also redness, blurry vision, and her right eyebrow hurts. She's covering her right eye because the lights really bother her, and the moment you walk into the room, she leans over and vomits. An acute red eye with severe eye pain, blurry vision, brow ache, with vomiting, get that tonal pen ready. Normally, aqueous humor, the fluid inside the eye, is produced behind the iris, travels between the iris and lens, through the pupil, and exits through the drainage angle at the front of the eye. In acute primary angle closure glaucoma, the iris presses against the lens, creating a block at the pupil. Hence, pupillary block. This stops the fluid from moving forward. The trapped fluid builds up behind the iris, causing the iris to bow forward, closing off the drainage angle, leading to a sudden rise in intraocular pressure. The eye pressure is often greater than 40 millimeters of mercury and can even reach the 50s, 60s, or even higher. And if it's not properly normalized, it can lead to optic neuropathy and irreversible vision loss. And this can happen pretty quickly, and these patients tend to be very symptomatic, which is what brings them in the middle of the night. Key signs and symptoms: severe eye pain that's often sudden and unilateral, a red, steamy eye with diffuse conjunctival injection, ciliary flush and corneal haze from corneal edema, blurry vision, halos around lights, a mid-dilated non-reactive pupil, go ahead and highlight that, and some clues of elevated eye pressure, headache, brow ache, and nausea vomiting, especially if any of these symptoms are associated with an acute red eye. Also, photophobia, light sensitivity, and the eye can be weeping with excess tearing. There can also be eyelid edema and anterior chamber inflammation. There are key exam findings that will help differentiate pupillary block from another red eye condition, and I'll list them on the screen. But a few that I want to highlight: number one, acute pupillary block patients tend to be miserable. They're usually very symptomatic and nauseous from the high eye pressure. Another key is the shape of the iris, which is bowed forward from the trapped aqueous humor behind it, pushing the iris forward. And this leads to the anterior chamber being deep centrally but shallow peripherally. And the third key exam finding is a mid-dilated, non-reactive pupil, especially if it's unilateral. So that's going to lead to anisocoria. So what do? As routine, check the 5-eye vital signs. And one of the most important steps is checking the intraocular pressure, which is often going to be greater than 40 millimeters of mercury in acute angle closure cases. And I'm going to sound like a broken record, but anytime the eye pressure check is elevated, greater than 21, check it at least 3 times to get an average and to confirm that it's truly elevated, because it can change the urgency of the management. If I'm being told there's concern for acute pupillary block, but the pressure is 18 compared to 56, well, the pressure of 56 is a lot more concerning. 18 is within normal, so there's likely something else going on other than acute pupillary block. If you don't have a tonal pen, or your tonal pen decided to go on vacation, what you can do instead is digital palpation. And this is where, using your pointer finger, have the patient close their eye and gently palpate the globe. Normally, the eye should feel soft and formed. You can even do it on yourself to get a baseline. But when the pressure is really high, it's going to feel more firm, kind of like palpating a rock. Another thing to do is to ask about glaucoma history and if the patient uses any eye drops. Sometimes patients have eye pressure spikes because they ran out of their glaucoma medications weeks ago. But unlike an acute angle closure, these patients won't have iris bowing or a mid-dilated pupil. What not to do? Avoid dilating the pupil, so no mydriatic agents. It could exacerbate the angle closure. When to call? Call immediately with the best corrected visual acuity and eye pressure checks, plural, of both eyes. Acute angle closure is an ocular emergency that can result in permanent vision loss within hours if untreated. Just as an aside, the management of acute pupillary block often involves glaucoma medication and a laser procedure called a laser peripheral iridotomy, or LPI, done by an ophthalmologist. This procedure creates a small hole in the iris, creating an opening so the trapped fluid can bypass the iris lens block, decreasing the eye pressure. So this was just one eye emergency, but what about the other times that you need to call ophthalmology emergently? Check out this video next.